Howdy, y'all. I'm Dr. Jeff Jarvis, and this is the Circulatory Support Protocol Review Module. This protocol is intended to consolidate interventions needed to address hypotension or dehydration, say, from across other protocols. Now, I'm an Aggie, as y'all may have heard.
All right.
And I like simple things. I much prefer to say something once and on one piece of paper than many times on many pieces of paper. I find that I write the protocols that I wish I had when I was working in the field, and I just find that I can remember things better if they're consolidated rather than scattered over lots of different protocols. Circulatory Support Protocol is a great example of this. It's in the general section. That's the home for the stuff you use in lots of different places. You're going to find that things from this protocol apply in many, many different situations. For example, anytime you think a patient needs an IV, this is the spot for you. Not the specific conditions to start an IV for. That's a clinical judgment thing, and I trust you to make that decision. This is just where it's authorized for you to do that. Keeps us out of trouble with the state. Now, for basics, things like positioning or hemorrhage control, manual displacement of a gravid uterus, that's called for and it's covered here. Hemorrhage control, again, because I don't like writing things multiple times, that is all covered in its own protocol, and we're not going to cover it here. Now, a note on why uterine displacement is a good thing. In later term pregnancies, technically whenever the fundus is above the navel, but basically anytime you can actually see an obvious pregnancy, the fetus gets pretty big. Ask any pregnant woman why they're going to the bathroom all the time. It can actually compress the inferior vena cava when mom is lying supine. If she has symptomatic hypotension, it may be because she has inadequate preload because her vena cava has somebody jumping on it. So just roll her over to her side or manually push the fetus off to the side. Move aside, kid.
Kick the baby, kick it. Ah.
Mom needs some blood. Turns out it works. Now, we cover several things in the ALS section, most of which are just references to their own protocols. Things like IV or IO access, 12-lead ECGs for cardiogenic shock, needle thoracostomy for suspected tension pneumothorax. As a reminder here, guys, remember, no hypotension, no tension, no Darty. Gotta have the tension physiology, which means hypotension. Push-dose epinephrine is in here as a temporizing measure until you can get an infusion set up or until you can get blood going if that's the issue, and we have it. Now, as a quick reminder on push-dose epinephrine, you mix it by diluting a milliliter of 1 to 10,000 cardiac epi in 9 milliliters of normal saline, and that gets you 10 mics per milliliter. You give 10 mics at a time, titrated to your goal blood pressure, and keep doing it every 5 minutes as needed. Remember, though, one more time, push dose, it's just a bridge to something else. Either time to let the fluids work, or more often, time to get the vasopressor set up. But it's just a bridge. So as a general rule, if you need to give push dose epi, you really probably ought to be setting up your infusion or pushing in fluids. Now, different conditions have different blood pressure goals, and because of that, I want to go over them here. So, TBIs, they do not tolerate hypotension. Well, in fact, even one episode of hypotension in traumatic brain injury increases the odds of death by over 300%. Because of this, we want a higher blood pressure goal. Specifically, we want it up to 110. So if you think you have a patient with a TBI, even if they have multi-system trauma, they have some blunt trauma somewhere else, but they also have a TBI, aim for a systolic of 110. Now, blunt trauma, that can tolerate some permissive hypotension. The evidence for this came from a study done by Maddox and Pepe with the Houston Fire Department. They did this when I was a paramedic student with them in the 80s. Love you, Blue, Houston. Go Oilers. If only they were still a team. I'm still bummed out about that. Damn you, Tennessee. The idea behind this is elevated blood pressure works against clot formation, in essence, popping the clot. That's likely not exactly what's happening, but it's a decent enough way to think about it. So our goal here is 100 systolic blood pressure in trauma patients and even lower in penetrating trauma. So 90. If they have hemorrhagic shock or penetrating trauma, 90 is your number. Now, don't give these patients more than 500 milliliters of fluid. There are several concerns with excess crystalloids in hemorrhagic shock. If you're on the med Twitters or the social media, you've heard some of our more obnoxious colleagues talk about death by pasta water, meaning salt water or normal saline. They have a tendency to overblow things because, that's the point of social media. But there really are a couple of concerns. There is this hemodilution issue where we end up diluting out the clotting factors with fluid that doesn't carry hemoglobin. There's also this risk of hyperchloremic metabolic acidosis or even hypothermia because we didn't warm up the fluids. All of those things are considered, what's the technical term for it? Bad. We want to avoid it. So no more than 500 mils of saline in these trauma patients. Now, for everybody else here, all of our other blood pressure patients or all of our other hypotensive patients, blood pressure here, just keep it at above 90. Or in the highly likely case where you're using the automated cuff to get your blood pressure, aim for a MAP of 65. How do you calculate the MAP? It's really easy. You get out your calculator and you throw it over your left shoulder and you look at the reading on your monitor. 65 is the number we're looking for. What about pediatric patients with any condition? We'll aim for a systolic of greater than 70 plus age in years times 2. So let's go through those goals again. I have this funny feeling Levi is going to put something helpful up right over here. So let's go through it. Pediatrics, systolic greater than 70 plus age in years times 2, or 90 if they're over 10 years old. For adults, if they have hemorrhagic shock or penetrating trauma, aim for 90. Blunt trauma, aim for 100 or higher. TBI, 110 or higher. Adults with all other indications, aim for a MAP, mean arterial pressure, greater than or equal to 65, or if you're manually calculating or manually taking it, systolic of 90. Now, our goal here is to keep the blood pressure at that point or higher, keep it from dropping below these goals. If they're running higher than the goals, we'll just leave well enough alone and don't give fluids or don't give anything else to raise the blood pressure. Now, if you're intubating them with DSI, that's a different issue. Follow the DSI protocol. Well, what about persistent hypotension below those goals in trauma patients? Well, the best answer here is clearly blood, and we're working very hard to get that into the field. But if it isn't available, go ahead and give the 500 of fluids and then no more. Then titrate in either push-dose epi or levofed to hit your blood pressure goals, but remember not to let it get above there. Now, obviously, a few points above or below, that's fine. This isn't perfection. Just watch the trends and try not to overshoot. Now, the other issue here is we have frequently heard don't give pressors in trauma. As a matter of fact, that used to be in our protocols. The problem is that patients don't deal well, particularly those with TBIs, don't deal well with hypotension, whether we have blood available or not. So we got to do something about it. Just watching them go into cardiac arrest, probably not the best thing. Yes, we'd rather get them to surgery, but that takes us time. So pressors in limited situations to get just to our goal, it's okay. We've had this conversation with the trauma surgeons. They understand what we're talking about. They have signed off on this as well, as EPAB does with all of our protocols. Please, though, make sure that if you get a trauma patient on pressors, Actually, for that matter, if you get any patient on pressors, when you get to the emergency department, please be sure that the staff knows that you have either given or are giving pressors. It can really change their management, and they really, really need to know about it. All right, next up is the advanced level. This is really about some specific indications, and we can hit this really quick. Now, first off, I want to give you a little bit of some education here about language.
Check this out. It's an ancient scroll, all in Latin. I translated it. Took me 6 years.
It turns out anaphylaxis is Latin for needs more epi. So, with that Latin lesson in mind, by all means, give them more epi. Give them all the epi. Anaphylaxis protocol handles the IM epi, but if you need to give an epi infusion, this is where it's covered. Start it at 5 mics a minute and titrate to your blood pressure goals above that we've just talked about. Same thing goes for symptomatic bradycardia that needs an infusion, C-epi infusions. Now, for any other non-traumatic hypotensive patient that's unresponsive to fluids, norepinephrine, Levophed is your drug. But fortunately, the dose is the same. 5 mics per minute titrate to blood pressure goals. Pediatric dose, fortunately, the dose remains the same for both epi and norepi infusion. 0.1 mics per kilogram per minute titrated to your blood pressure goals. Now, finally, the case of hypotension in patients with documented history of Addison's disease. That's adrenal insufficiency. So in addition to doing the other things we talked about, be sure to give them dexamethasone. For adults, give 10 milligrams, and for kids, give 0.6 milligrams per kilogram. For either one, you can give it IV, IO, or IM, and in kids, you can give it orally too. But if I'm being honest, if they're sick enough to get it, they're probably sick enough to need an injection or an infusion. Not an infusion, an IV or an IO. All right, guys, let's hit the key things one more time to summarize. If you think your patient needs an IV, then give them an IV. Same goes for IO. Review the blood pressure goals in this beautiful display Levi's putting up right here. Do you see it? It's right there. There you go. That's it. Epinephrine is the antidote for anaphylaxis. Norepi is the infusion for almost everybody else. Push dose epi is just a bridge to something else, whether that's more fluids, blood, or a vasopressor. And finally, don't forget Dex for Addison's disease. Finally, it's okay to use pressors in hypotensive patients if 500 mils of fluid didn't do the trick. Just try not to exceed your blood pressure goals and be sure to tell the receiving facility they got pressors. That's it. Thanks for listening. As always, I welcome your questions and love chatting with y'all. Hit me up, email, come by the office, give me a call. Let me know what's on your mind. And as always, thanks for what y'all do to take care of our community every day. Take care, y'all.